Pledge allegiance
to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Okay. Danielle, hello.
Hi.
Welcome.
Thank you.
Any public comment? Seeing none. Moving on to the consent agenda. One little change for the minutes of the prior meeting. I was not here, so I couldn't have called a executive session.
It's the last paragraph.
I'll make that.
Okay.
Do we know who did call it?
I would believe that.
Yeah, Cheryl, I did.
It's just a, that's just, yeah, typo. Okay, approval of the consent agenda as adjusted.
I so move that we approve the consent agenda. Second?
Moved and seconded to approve the consent agenda as adjusted. All those in favor?
Aye.
Opposed? Hearing none, passes unanimously. Okay, Cheryl, you're up on the hot spot with the brand new July financial report from the new program.
Ish, yeah, ish. So, this month was July, of course, was the first month of the new year. We don't have any year-to-date reporting, because month and year-to-date is the same. This month was really a crazy and amazing, incredible month for the accounting staff and all of the business office. So I wanted to just, give you a picture. We are currently billing out of Cerner and Credible for wellness and PCC for long-term care. But we're posting payments into ECW because that system is still functioning. CPSI, Credible, PCC, Cerner, and Multiview. So we are posting payments into 7 systems, and all of these things are coming together into Multiview to help us to result in our financial reporting. Our staff has absolutely put billing and collections first because we know that that is our biggest concern. Keep the bills going out the door. I'm going to give Susan a chance to talk about that later because they continue to do an amazing and incredible job. We talked a lot about that Cerner model before. That's a big concern. How were we to fall in that model where they show that you're only going to let 60% of your normal amount of cash, it kind of goes down. 70 drops down to 40, worst case scenario 40 in 1 month. So, we talked about that year ago. This month, their model predicted that we would collect between $1.8 and $2 million, whereas we actually collected $2.4 million. So we're ahead of where we need to be, 25%. So I don't see any reason why we're gonna fall behind, but that is amazing news, and that's the most important thing that we could be doing and getting it done. This week was the first week that we processed payroll under our new system, Kronos. So our payroll staff has spent a huge amount of time getting ready, and payroll staff is also accounting staff. So there's crossover. Shelley's dedicated to payroll, but Jerry and Natasha do payroll, and so a lot of their time was taken up by Kronos. That was a really, really big deal in my mind, and it was extremely stressful. We were already short a day this week because Monday was a holiday, so processing payroll in the new system was a short day. They did get the task done. I know that Shelley was about as stressed out as I've ever seen her, but she got it done. And yeah, there was some mistakes. Huh?
How often is payroll every 2 weeks?
Yes.
Great.
Another thing is that audit fieldwork begins next week. So the accounting staff has also been working on preparing all the documents for fieldwork. And we've been doing that for a few weeks, but it's more intense if that one's fieldwork. And you really have to get it done. Yes.
Just for everybody's enlightenment, including the audience, would explain the field work?
Fieldwork. The auditors from Whitley will be focused on LHD. So they come and they look at all kinds of invoices, and they look at AP, and they look at our journal entries, and they look at our financial statements, and they look at whether or not we're following appropriate accounting, security models and whatnot. So they have a lengthy, several page list of documents that we need to prepare. They want to see all the copies of the board minutes, they want to see, it's a long, long list. So next week is the week that they're gonna be here, and you have to have all of that stuff done, ready for them to look at.
What you were, if I can just
Did
comment,
I miss the mark there?
what you were saying, they were asking is they'll give us a list of all sorts of documents that we need to produce. And they'll select a number of documents from accounts payable. And so the field work is to gather all of that and prepare it so when the auditors get here, they can start looking. Okay, that's what takes so much time to do. Sorry.
Are they integrating also with the cost report at the same time?
Well, the audit really kind of needs to be, it's the groundwork for the cost report.
Sure.
The cost report really comes next, but they sort of start and end with the audit. The audit just kind of goes off the middle. I mean, the cost report has a really hard deadline, as we know.
Right.
So something for everyone to keep in mind. Many hospitals that are critical access hospitals like ours, not only do they do an audit, as we are required to do, they also have a cost report. Some choose to have one company do both. Some choose to have two companies, two different sets of eyes looking at the same sets of information, or similar sets of information. So the audit validates that what we are reporting to you is accurate, that we haven't done anything inappropriate. Cost report is what we file with Medicare. That is how we get paid for our Medicare services. And then once that is approved, Medicaid in the state of Oregon accepts the Medicare audit report, and they use that as the documents for which they determine what we did. Okay, so it's two different things that are occurring. We've chosen, certainly for as long as I've been here, and I can't recall if it's been a whole lot longer, have one company do both the audit and cost report. Just so,
You were paying more if you had a separate company.
Right.
So, okay, and then last, we also have we've also been seeing EMS starting up to occupy the EMS building, so our business office staff has once again been on the move, and with the IT issues we've had and some people moving to work at home, and it's very disruptive when you have to move your staff again. So I say that because in spite of the fact that they're moving again, they still have been achieving amazingly well with Cerner. You wanna talk about lights on now?
Where are they moving to?
Well, they're just moving around inside the EMS building right now. So, we needed to vacate some space for the new director, where his office is going to be. And we talked with him about what he want, because we thought we might move them all upstairs so they could kind of be out of everyone's way. But he said that they would prefer to have the upstairs, and they would do their training and stuff upstairs, and so we stay in the main room. He gets an office, and so we kind of vacated half the kitchen and a few of the spaces that we were in, and so we're trying to consolidate. And then we've got a few people that will work from home. So,
What's the size of the staff?
there.
So we started, let's see, I have 7 that went remote and I have 6 left over there. And then I have another handful that are up front. But in that space, we moved 7.
What's up for me?
So I have the admitting staff and I have a coordinator and 2-3 billers up there. That sit up front here. When we lost our space in the back, we had to kind of divide it.
Essentially the 7 seats being used over there.
that six of us left over there was my head count today.
People up front here need to be available to patients, that's, yeah, maybe. So, anyway, okay. So, do you wanna talk about one of the best, the greatest things about, I guess what I didn't end up saying is the financial reporting, therefore, this month, for July, is a little on the light side, and I realize it's confusing. So the detailed report that you got, there aren't actually duplicates, it's just that some of it has, it each has different sets of data, and there are some subtotals. It's not very well labeled, so we will definitely get it fixed for next month, so the labeling is more clear. Also, we don't have the budget data and the prior year data loaded up in a way that we can present it to you yet, because we did end up moving things around, and this is your golden opportunity to make it exactly how you want it to be. And anything that's changed, you try to keep it the same, so you have comparative financial information. But this is the time if we wanna, take oxygen out and show it separate, or get a little bit more detailed departments, this is the time to do it. So there will be more changes. I didn't have all the charts that I would love to have. I don't have statistical data that we would normally look at. It makes it really hard for me to tell what's going on without statistical data. We just had our, what they call the DA2, the data analytics, discern analytics. Cerner teaches you how to build reports after you go live. So they teach you in your own system, using your own data, and they only let 7 people go to this class. So those people just went to this class a few weeks ago. It's like a 4-day class. So all of those people are now trying to figure out a very complicated system to start pulling the data out of Cerner the way that we needed to, and medical references. Not there yet, but they're working on it. So I don't have statistical data. But we do have this really cool thing called Lights On Network that, we kind of drool over it almost every day. And we're going to start pulling information out of that. We'll put it in our
3 times a day.
maybe 3 times a day, yes.
I think Cheryl's excited about this.
I am very excited.
What do you call it, remind you of the church?
It's called
Lights On.
So
This is a dashboard that we get to see. It updates daily, so we get a snapshot of pretty much all things. The one that I log into, I see all of the financial stuff. There's lots of other ones as well. But obviously we focus on the financial one. And so I can see charges from the previous day. I can see a 6-month average once we have 6 months worth of data in there. I can see daily what collections for that day were, what charges were. I can see DNFB, I can see days in coding, I can see if there's things sitting ready to build that haven't been pushed out yet and what those days are.
And those were the things you had trouble seeing visibility in the system.
I could see almost none of that.
like
Nothing at a glance. This is all on one dashboard that pops up, and then you can drill into each thing. There's charts. But what's really exciting is that I can see on a daily basis what it is that needs improvement immediately. So I can see that, okay, I have staff like today, I can see that my days that are sitting ready to bill, so it's ready to push those claims off the door, are at 1.08. Normally I see them at 0.75. What's going on? Okay, I had 5 days of no, I had 5 billers that couldn't bill for 5 days. So that explains why I'm off a little bit. So we can really more fine tune what processes are broken or not working, so that we can impact them faster and have a better turnaround to collect and get claims out the door, resolve issues, things of that nature a lot faster. So we're kind of data nerds, and we're all really excited because you can also see the change. It shows you daily exactly where everything is going. So it's a lot easier for us to help manage staff and see what things have been touched, what things need to be touched. Oh, hey, we still have an edit issue, so we need to get that resolved with Cerner before we go to long-term support, so that we aren't getting things stuck in the scrubber because we have an edit that needs to be turned off. So we can see a lot of things. We share those things with the staff on a daily basis at our morning huddle. So we worked with some of our staff remotely previously during COVID, and we had a really great success with that, so we are embracing that model again. But the critical part of that is that we all meet at 9:30 every day to discuss what happened yesterday, what's happened this morning, and where we're going. So we wanna make sure that everybody, even though they're not on site, they are still very involved in the day-to-day operation and what our expectations are and making sure that we're meeting their needs.
Susan, can you
Yes.
tell individually what each one is producing or performing
I can.
as well?
I can. So my remote staff actually they submit to me daily a time study, so I know exactly what claims and accounts they've touched. I have access to several different reporting methods where I can see every chart that they have touched, every claim.
Whether they're remote or not.
Yeah, whether they're remote or
Sure,
not. I can see everyone's productivity. I can see a number of different things that tells me how productive they have been. And then they will also be receiving, so we're running several audits on the back end as well, so they'll be receiving a monthly snapshot or report card, if you will, of what their performance was based on legacy collections, current, what their bills going out the door were, what their collections are within Cerner and in legacy. So we've set up a model to make sure that they're meeting all of these benchmarks so that we can make sure we stay ahead if anything looks like, hey, maybe we need to return somebody to campus so we're not as productive as we could be, or maybe there's some other reason why they're not being productive. But yes, we can drill down very, very deeply into what the details are.
And it's real time,
And it's, next day.
or pretty darn
Yeah.
close to it.
Have you guys feel that the Cerner support that they promised when we took this on has been there and you're satisfied with the support you're getting?
Yeah, I would say from
Yeah.
patient accounting and finance, I think very much so. We have not turned over to long-term support yet. We're targeted not to turn over for 90 days or when we reach our pre-go live
They've been
metrics.
very responsive.
They've been very responsive.
So keep in mind that that's one part of the software. There's the physician side, the nursing side, that has a
Oh, your
different
different
answer.
vet, she's.
Yes.
Right, because you have very different, it's a huge company, so you have different parts that are different
And it
levels
impacts
of
people
quality.
in different ways.
Yeah.
So keep in mind, not everything's perfect. We're doing a lot of really great stuff in certain areas, and some other areas we're struggling. Okay?
So Gerald, you better be prompt in paying your bill because they're gonna know.
Better reach for my wallet right now.
I think that the last thing that I'm gonna touch on just briefly is that we also from our scrubber, the place that sends out the clearinghouse that sends the bills to the payer, gives us some great reporting packages also. But what's really exciting is that, so I just told the last week, we were at an 81% clean claim rate. So that's awesome, that's amazing. And what that means is that everybody downstream from us is doing what they need to do. So that's really, really exciting for our facility to know that we're approximately 7 weeks into our new system and things are going smoothly enough that we can have that many claims going out the door. So, all right, sorry.
You mean upstream, like the providers?
The providers,
staff,
nursing
all
staff,
people.
registration, I mean, we're looking at
They're,
touching 20% of the claims.
they're using the system like they should.
Yeah, so it's doing what it is, or what it should, even though
So
we're,
this will speed up the cash flow from the insurance companies, Medicare,
that's the
Oh,
whole.
right.
Cross Blue Shield.
Yeah, if we have
Right.
fewer rejections, you get paid faster.
It is good. Okay, so now I'll run through what I got really quick, okay? So this would be where we're at with our patient gross charges, $3.7 million, which is really not a bad number at all. It's a little bit lower than we budgeted to be. Our collections, like we discussed, were at $2.4 million right here. Lower than we needed to be, but I think a very good number for us for this month. Our days cash on hand dropped to 81 because of course we didn't collect as much money, so I'm not really surprised by that. Still not really a bad number, I think it should recover in the coming months, especially if our revenue stays steady, which I feel like we're pretty busy. Operating revenue for the month of July was $3.1 million, our expenses were 3.3, so we had a loss of $400,000. So we did, one of the things that we did do was to reduce the patient counts across the departments to allow people to learn Cerner. So we did, part of this month, we definitely limited patients to make sure that the doctors and the staff had time to use Cerner. Obviously, we can't do that in the hospital, so they had to just struggle and they were extremely busy, but everyone else was able to limit their patient counts, so that of course had a negative impact on revenue naturally. So the loss for the month was $232,000. Last year at this time we lost $48,000, so it's a little bit worse than last year. Last year had a rough start, but then really bounced up. Budget versus actual, we budgeted for 3.3 in net revenue. We talked about why that's low. Expenses were high. We certainly have a lot of contract labor. And we have quite a bit of overtime with that go live, so, and then we have, what else was I looking at? So anyway, so the loss 232, less we budgeted 280. So that's it for Lake County District.
Questions?
Brief, but not bad. This is what we should talk about.
Tom thought we might wait until the CEO.
Okay, great, cool. So then, Lakeview Gardens, I believe that we added a person in long-term care, so we're at 21 in long-term care here, we're at 10 in assisted living. Which leads to long-term care had revenue of $238,000, last year's average was $204,000. In assisted living, our revenue was $42,000, last year's average was $49,000, so we're here in assisted living, and here we are in long-term care. Seems like they kind of trade, we can just trade places, being busy or not busy. The revenue was $238,000. And now I sound like a broken record, but wages were $140,000, labor was $120,000, loss for the month was $164,000. I'd like to see that loss at $85,000.
Keep in mind, we're very restricted about who we can admit to this. They're our most vulnerable portion of the population for COVID. And so we're very restricted on who can go, who we admit. So we have patients, for example, right now, that are in our swing bed program that could, when they are discharged, go to long-term care.
There is a quarantine.
No, I couldn't say that specifically. There's some, a little bit of that. But we are very, very careful about it, because that is the last thing we want to do. We have not been, we've been blessed with not having a lot of COVID patients. In fact, I think the last time we tested someone positive was the end of July. So now it's possible that in about 10 days we might see this. After roundup, Labor Day, the time when a lot of people are out of town. Hard to know. We're seeing overall in the state a drop in cases, so we're not anticipating an increase in cases, we're just being prepared.
Nationally, is there a projection for increase as we enter winter?
I think the bigger concern is many of the symptoms of COVID are similar to flu. And so there'll be a lot more testing. When there's more testing, you seem to find more cases. It's uncertain. Certainly after people start going to school, are we going to see an increase? Some predict we will. It's not clear. We just have to wait and see.
Just as an aside, is the flu vaccine available here?
It won't be available until, I think, October. Is that what,
Yeah, we're projecting that we'll have it, but it has not arrived yet. And the state has apparently guaranteed or promised additional doses over and above what we've ordered. So we'll go through what we order, and if we still need more, we'll have it from the state. So the supply should be adequate. I We never know real close because they just sort of ship it to us. We don't get a lot of notice. So we should get it in October.
What also happens is, while for whatever reason, our big time of having flu is in January, not in October. Whereas other parts of the state do have a greater increase earlier in the winter season, so it's hard to tell. And we get doses both from the clinic, the hospital, and of course, public health. So we have lots of places where it is. And it is available at hours also, when they get them, when it starts over.
Anything else on financials?
No, that's it, sorry.
Okay, Marty. Okay. Did you go over the Bruce Lake Medical Service too? You did, didn't you? Okay. Mr. Twait, the ambulance service update.
Amazing. See this here? This is our license. Thought everybody might like to see. This is the license that says from the Oregon Health Authority that this is the ambulance service license for the Lake District Hospital. And so that went live as of September 1st. We have a new EMS director, Troy Armstrong. Troy said to me when I met with him on Tuesday that I believe he said we estimated based on the information from the disaster unit that they were doing 5 or 7 runs a week. He said he did 16 the first week that he was here. So I asked him to come to the board meeting next month, not this one, because there's just still too much going on and a lot of changes as we're progressing.
You had to move the staff out.
Had to take over the kitchen.
So a lot of things happened. He gave me a little report so he's working on getting staffing worked out, schedules worked out. There's some modifications to how things were done versus now how they're done. The disaster unit met this past Monday night and approved the lease agreement. I sent a copy to you, John. That is, it went from leasing all of their equipment, 3 of their equipment, all of their equipment. It's now at all their equipment. It went from $1 a year to $60,000 a year to $1 a year instead of $1 a year. So there's been a variety of different evolutions to the lease agreement that's now finalized. One of the things that Troy is doing is we are getting, we started off with an inventory of what's on each vehicle. He's going through and making sure that that is clear and we know what we have. Because when we lease the equipment, when we're done with the lease, we want to say, well, this is what we started with, this is what we end with, so that everyone agrees to it. So he's working on that. We've got there are 3 vehicles that can be licensed as ambulances. The others are vehicles that are used for rescues, so they could go off-road or not on the highway. So if they take somebody from, there may have been an off-road accident, or there could have been some reason that they bring it from the rescue vehicle to the highway, then they would put into an ambulance. Those ambulances are licensed. And we have to have the licenses. In order to have this license work properly, we had to have the name change on each vehicle before the license took place. So it was a coordination of change.
Have they been rebadged?
They have.
Did you see the parade?
I did not.
I noticed the signs well done.
So, I mean, that is a requirement. These are all state mandated requirements. It wasn't something that we're trying to be difficult. We actually still have to have the ambulances all evaluated by a licensed technician. They're working on scheduling their that in the next 10 days. Somebody coming down from Bend to actually provide that service. One of the advantages that we have over the disaster unit is because it's a government-to-government, they're allowed to do the inspection. Versus if it was a government agency then to the Lakeview disaster unit, they couldn't do it. They had to have somebody come from Farm and have that inspection from a farm. So it was just, it's the way the rules work. We're working through setting up the fees, so we'll start building for that right away. As soon as I finish that process. So there's a lot of things that are still underway.
So have they been brought here now?
We have one vehicle that's here, and they're beginning to move the vehicles as they get all the things that make sense. Public transport. It's in process. Any questions about the this new exciting process or change? It's been a long time process. There's still plenty to be worked on. The kinds of things we're working on right now, Troy, we had planned that we would get, I don't exactly call it a chase vehicle because that sounds wrong, but you have like a fire chief going out to the site. It'll be a vehicle to assist if there's an off-site need for an ambulance, but you don't have all your equipment or don't have all your personnel. The ambulance is on its way. You need other people to go and support the process. They'll come in a non-ambulance vehicle, something like a Tahoe or a Suburban that will follow with it. So we'll be buying that in the next 30 days. We're also looking at buying a transport vehicle so we'll be able to do inter-hospital transport. So working on that with staff. And there's just a lot of things that Troy's got his hands on. And he'll be able to give you a good update.
Good.
Anyway, I'm pleased to say that I was very, very fortunate that he started right on the first also. Actually, the 31st. We thought it would be September 15th.
Where was he moving from?
Moved from a great state of Missouri. A lot of good things there. And still being negotiated too.
That'll probably be an ongoing process for a while.
Absolutely. I don't believe we have any medical staff update. Jen did not give me any, so I don't believe we have, so sorry about that.
Okay. Teresa, nursery report. You're
Wow,
up.
you guys are so sweet, I'm not ready. It's almost over. I just have one little thing to share with you that I thought the team did really well. You can have a look, because it's a quality report.
You'll want these back.
So I'll want it back, thank you, you're well trained. The thing that we work on all the time,
This is Jen.
this is Jen, okay. So the thing that we work on all the time, one of the quality measures we've worked on for several years is decreasing readmissions. So the goal from CMS and Medicare is that we don't, that we discharge patients in a way that they don't come back to us for any reason for 30 days. That's the measurement. So we don't have readmissions for within a 30-day period. So we look at that regularly, and we started several years ago with a readmission rate of around 30%. And we thought it would be impossible to really decrease that, but some people have worked very hard on this. Our case managers have worked on this, our patient navigators, our chaplain, and now people from both clinics, both the Lake Health Clinic as well as Warner Mountain Clinic, all get together every week and they discuss patients. They discuss the patients prior to discharge as well as they follow them for a month out. And so people make interventions, whatever that is. If the patient can't get their meds, if the patient can't get to the doctor's office, if, whatever the barrier is, if they need physical therapy, all of these things are taken into consideration. And our readmissions team discusses them, decides what they can do, and this last quarter, we actually had no readmissions within the 30-day period. So that was a huge gain for us, and I just wanted to share that with you. So that requires a lot of coordination from that group, and they've been, we've worked on this now for several years. We first identified a tool to rate our patients for risk of readmission. And there were some national tools, but they didn't really fit, as always happens in Lakeview, right? It doesn't quite fit. So we made our own, and so we, just found the things that we find that people are readmitted for. The primary, one of the highest ones is patients with mental illness. And so we bring in the folks from the Wellness Center and they do follow-up visits or, whatever it takes to try to get them connected with a provider at Wellness Center. So that's part of it also. So at any rate, I wanted to share that success with you because it's really good.
Congratulations.
Yeah.
Yeah, absolutely.
And extend to all the people who work on it.
Yeah, thank you. So the other thing is, Charlie wanted me to mention how it's going your sooner. I don't know if I can be quite as glowy as Susan. So we've had a lot of challenges. It's a big transition for us. There's a lot of things that we still, I know today they worked to transfer patients from acute to swing bed. They worked on 4 patients today, and one of them they could never quite get done. So, there's some things in the system that are not easy. So we're still struggling with some of that. Our providers, I have to say, have been really gracious about this huge transition. I think really, even in comparison to the transition that we made to CPSI, I feel like they've made a really gallant effort for the most part. It's been a drain because up until this week, we staffed our nursing staff, our super users, we staffed every single day, an extra person. And for part of that, first part of that, it was every single shift to work with nurses and to work with providers. And we've brought in a consultant to work with the providers who's been successful. He's an independent consultant who has expertise working with providers and cerners. So he's taught us a lot, but it's a slow process. There's a lot to learn. It's a really big system, and we're slogging through it, but I can't say that it's.
But has Cerner been responsive for when you've had real problems?
I have to say that it isn't as though they aren't responsive. It's a process. It's a time-consuming process to put in the request for their intervention and to make changes. It's not as easy as a phone call. It's logging in and describing the change and sending screenshots of what we see and what we want changed, and it's just all really time consuming. So
but the progress is steadily.
It is, progress is in a steadily positive direction. And I mean, I have no doubt that it's going to get better. It's just,
Slow.
yeah, it's slow and there's still some pretty significant things that we have to work on. So it's a huge culture change for us.
We'll get there.
Yeah, we'll get there. And I think that the end result that Susan is seeing is the really positive thing about Cerner is that a lot of the collection of the things that need to go into getting the bill out the door is done from the beginning all the way through. And so that's one of the real positive things about Cerner. A lot of bills are complete when after the patient has surgery. The bill is, kind of done at that period of time. It doesn't have to go through a whole bunch more folks. We're still auditing things and finding things, but there's a lot of things about how that part of it works financially that's very positive. Just have to make the other side work.
Appreciate your effort.
Absolutely.
Thanks.
So is it, are we starting to get this integrated in patient logging in the patient portal online? Or is that still lagging?
It's not there yet, still, it'll get there. It'll get there.
I think their portal works a lot easier. But I haven't tried myself, but it felt like it was a way better portal than what you saw in CPSI.
Which was very important.
Yeah, it was cumbersome.
It was.
As we have a younger generation coming out that's a little more astute than some of us others, it'll get better as time progresses, right?
Yeah, and definitely you're right. The younger nursing staff adapt to it better than some of the older ones. The portal itself, I'm sure, will be easy to navigate for younger folks. Questions for me?
Well, I don't know if this is a question for you or Charlie, but one of the things we were sent out in our board packet was this stoplight report, which shows things that are green, yellow, and red.
Quality?
Quality, yeah, yes.
Okay.
And one of the areas that we had a challenge with in this last quarter was discharge information. I don't know if you
Was that the patient satisfaction scores?
That's the
Yeah,
MB-Quip
yeah.
that comes out.
Is it MB-Quick or is this the
It's not MB-Quip, but it's
the patient satisfaction score?
It says NRC Health.
NRC picker, yeah. You're right. We talked about that. That actually has not been consistently a good rating for a while.
What does that discharge information mean?
So the patient is saying that they didn't necessarily know what they were supposed to do when they got home.
Oh, I see.
They didn't necessarily understand what symptoms they should be concerned about when they get home. We gave them that information, but this is their perception. So, I mean, we had to give them that information. So it was either how we delivered it or those documents were the documents that came out of CPSI. So we have a different document to use now with Cerner. We'll see if that's better. We've also I've had a meeting with the case managers who are responsible for discharge planning. And while they were doing that, my only thought on it is the patient didn't always know we were doing it. So we were always deciding, does this patient need help at home? Do they need medical equipment at home? We were always doing that, but I don't think we were communicating it well enough with the patient. So we're working on a little bit of a change in how they interact with the patients to see if we can improve that score. So you're right, that has been a bit of a lower score.
Well, it was the only area that was showing the red.
Yes.
One of the things about that tool that it really helps us is no matter what we say, we think we're communicating. What matters is what the person hears. And how do they understand what they hear? Sometimes we think they're literate and they may not. An example of medical literacy is if your doctor says, here's a bunch of pills, take them twice a day. Does that mean 2 in the morning? Does that mean 1 in the morning, 1 at night? Does that mean with meal, without meal? Does that mean, a lot of people don't know. And so we may think we know what it means when you say take them twice a day. But that doesn't necessarily, patient may not exactly understand.
So are they handed a list and then it's gone over with them? And whoever administers that, do they ask them, do you understand this fully? Because I mean, just that little phrase.
Right, I think we pretty consistently ask them that. I don't know if they use those exact words, and that's something I can work on is the words that they use, but I guess I will say that our process in CPSI could take us, because it took us a really long time to get through all of the papers. I think that discharge was painful in CPSI because of that length of time. And if you think about yourselves, when you're discharged from the hospital, you're in a really big hurry to leave. So you really don't want to listen to a nurse.
No.
You don't want to wait for the 2 hours that it took us to get all your papers together and get all your stuff returned to you. The discharge process in Cerner takes about 15 minutes. So I'm hopeful that the change will give the nursing staff an opportunity to be able to talk when people are still listening.
So is there anybody who can act as an advocate for patients to help them understand?
Well, we pretty much always talk with whoever their identified caregiver, husband, daughter, son, whoever that person is, are usually included in discharge instructions.
Yeah.
But like I said, it's this real critical little window of time that you have. We're waiting, the doctor comes in, says you're discharged, and then boom, you want to be out the door. So we have to get in that little window of time and be able to have them hear us. So we'll just keep working on it.
One of the reasons we give you these reports is because we use those tools to help us know where we can focus our energies and for you to understand what we're about.
That's good feedback.
Exactly.
Good.
That's great.
Okay, any more questions for Teresa? She's on the hot seat. Okay, hearing none. Thank you, Teresa. Good report. Now, Mr. Twait, the CEO report and budget request.
Yes, we'll start off with the budget request. I did not give you copies. I didn't have that information until later on, but these are issues that sometimes I like to think that are non-budgeted items or things that we should have known, but oftentimes they're just things that no matter what we do, we can't always know. So the first one is a bronchoscope. So bronchoscope is a tool that is used in the operating room by surgeons. And our bronchoscope that we've had for quite some time, did not anticipate having to replace it, got recalled. So we have to replace it. It's appropriate to replace it. We're going to get a better tool. We're doing more surgery, so that's a good thing.
Is that bronco like a horse?
It is bronco like a horse. But it is a different kind of bronco.
It's like the bronchus.
Dollar cost, Charlie? A different
The
price.
cost for this is, with the trade-in, is $18,764.
What does it do?
It is administered by Teresa.
Well, it just goes down into the The first part of the lungs, so the larger airways, it can go down and have a look. And it does a variety of things. It can take a biopsy, it could suck out extra mucus, it could just look and see if you have some sort of growth or problem. So it can do a variety of things.
One of the things that we, it's easier to buy things that are tools that we provide patient care to. We can generate revenue to pay them off quicker. You don't get to do that with room. It's just one of those things you have to do. You can't operate without a room. So these are items that are patient care items. So it's $18,764.50. Second item, we anticipated having this done before the end of last year, before the end of June. This is monitoring equipment in our pre and post operative, it's called the PAC unit, post acute care unit, no,
PACU,
PAC unit.
post anesthesia care.
That's it. And we have struggled with our monitoring equipment, but this equipment needs to be purchased for that area to be able to report into our server. It's all connected. It's the same system. This PACU monitoring system is $15,937. And of course, the next part about that is, in order to connect it to Cerner, there's the $6,000 Cerner connection cost, plus $5,000 in the equipment and maintenance and that sort of thing. So that, the Cerner component of the cost is $10,779.99, to be exact. So, here it is, the second month of the year, we're asking for non-budget items. We need to have them, we will figure out what we are not going to purchase, probably toward the end of the year.
And so moved that two non-budgeted items requested be approved as presented.
And the Cerner component.
Second.
Okay, moved and seconded to approve the budget request for the items noted. Any discussion? All those in favor, say aye.
Aye.
Thank you.
Passes unanimously.
Next thing is not good information. Dr. Gail Keneally, just hired for our alternatives office. She worked for us for a whole total of about 2.5 months, and she gave us notice. So once again, we're back on the hunt for another position in it. Disappointing, but
Is that 30 days notice or 30 days?
120 days. Unless we find somebody sooner, which I'm very happy to skedaddle down to Los Angeles as quickly as possible. So, sorry about that. It's one of those things. As Teresa said, we did not have as much support for physicians as we had hoped from Cerner. And it was surprising to me that they were going to be not as supportive. I think in part the COVID issues has made it more and more difficult. We were very fortunate to have the hospital in Astoria, Columbia Memorial Hospital, send 2 people down here for a couple of days. That was a very gracious thing. Now, they've been on Cerner for 5 years, and they were enormously helpful.
Working with the physicians.
Working with the physicians and with the nursing staff. We learned a lot of things from them. Number one, no is not an appropriate answer. If you ask somebody else, you get a better yes. We learned a lot of tricks and other things that they've learned over the years. As much as we don't want to say this, when you talk to anybody that has gone through, any organization that's gone through transition like we are going through, they talk about year 2 is better, but year 3 is even better. So when we are on this for 7 weeks, we have a road to hope. And we don't want to lose our focus. We did bring in a consultant to help our physicians. We may have to do more of that because I don't see Cerner being as supportive. And yes, our physicians are actually using the system. It's hard. It is, they've done extraordinary. And please keep in mind, when we switched to Cerner or to CPSI, there was a fair amount of reluctance to use the system. And there was a fair amount of reluctance to use our clinical system, which was in the clinics. So there was a fair amount of, we're still going to use paper. They're trying very, very hard to use the Cerner. And that's hard work, especially as we've been very busy. And then COVID on top of it, and all the anxieties related to that. So the staff is to be absolutely nursing, business office, everybody has done a fabulous job. Some are finding it easier, others it's not as easy. We went live with Kronos, as Cheryl said, with our first payroll, and it got paid out today. There's, as I said to Cheryl yesterday, there's still a lot of things that I don't know and I was approving, so it makes me nervous when I deal with that.
Did everybody have to make a check?
No, we do. And there are some bumps, but you know, anytime you change systems, that occurs. The next part of that Cronus install occurs in October when we go live with personnel, purchase and payroll. So it's a staggered process. What also began this past month is the process to convert our mental health, wellness staff to Cerner. That will go live in about 10 months. So while we were going live, wellness is starting their 10-month sojourn to switch from Credible to Cerner. So there's a lot of moving parts and a lot of people involved in these transitions. And at the same time, we want to take care of patients. So if we've had people that have been stressed out, it's understandable. And unfortunately, we lost one of our key nursing informatics people. Something about grandkids, I don't know. So we're in the process of looking for a replacement. We have a part-time person who's helping us, but as they described in the story, and most of the other hospital systems, when you switch to a new system, you have a lot more informatics stuff. It's more complicated, it does a lot more, but it takes a lot more people to do. So when we look at our informatics and IT staff, other organizations of our size have doubled the number of staff. It's that complicated. And you say, well, that can't be, it's a better computer system. The answer is garbage in, garbage out. So we want to make sure we're getting really good information. And that becomes better tools. We're not there yet, but those are going to be the challenges of what it is. So, probably the most significant thing that I'm sure many of you are thinking about are the fires that are occurring right now. I was on a call this morning with the Oregon Hospital Association, most of the hospital CEOs in the state. It's frightening. It's absolutely frightening what's happening in our state right now. Based on the number, they closed Lincoln City Hospital and moved everyone in 2 hours to the hospital in New York. They evacuated the hospital because the fire came a mile out of the hospital. It is estimated, based on all the different locations where the fires are impacted, that at least 250, that was as of this morning, 250 staff members lost their homes so far. So, what impact will that have on us? We're beginning to see people coming to town from out of the area, if they can get here. We already have people that are not going to be able to get here, or haven't been able to get here because of road closures. The administrator at the Salem Hospital said, one of the commissioners who lives in Detroit was not sure. It took them 3 hours yesterday morning to get to Salem from Detroit. It was yesterday or the day before. And they weren't sure their car would not burn up before they got. The fires were on either side. It was pretty frightening. So a lot of hospitals are on alert. That is important for us to know because we refer patients to St. Charles, we refer patients to Bedford. We're looking at the impact of what would happen to Bedford if the fires got worse and they would have to potentially evacuate. There are a lot of concerns, but the hospitals are talking with each other about how they would share. Supply chain could be impacted. Ours was impacted yesterday. Our materials arrived today. So the roads. So,
Do we anticipate a high rate of respiratory patients that may be transferred out of that area to Eastern Army?
I don't know if we're gonna see we would be the appropriate place where people would send patients. Portland is, of course, very concerned with they could handle OHSU, the urban hospitals, how they would deal with that. Providence talked about how they had to close one of their assisted living, so they took over a hotel. Put all their assisted living clients in the hotel. And figure out how do they get staffing from it's complicated. So I want you to be aware of this, but that we are trying to be as thoughtful as we can. Well, what do we do in the event we have problems? Any questions? You mean to be on the down note, but these are challenging times. One of the things they were concerned about in Lincoln City, for example, is they were worried if the roads get closed, how do you get the ambulances to haul patients from one hospital to another? How do they do that? We're taxed. But we're resilient and people are very committed to what they do.
Okay, any other questions for Troy? Okay, with that, do we have anything for executives? Okay. So we'll adjourn to executive session under ORS 192, 660, bracket 2, bracket 2.